Hi guys, this is Jens Chapman, and welcome to our interesting case discussions on Tuesday evenings here Pacific time. Today is May 20th, 2024. I'm Jens Chapman, and today Dr. Alekos Theologis from UCSF and several of his partners are going to talk about sacral fractures, a topic that's near and dear to my heart. And we're actually doing a sacral fracture right here, right now in our OR, but I'll be all ears. Our colleagues from Dallas have unfortunately had bad weather problems, so they all are kind of offline right now, but they may come in a little bit later. Alekos, thank you so much for taking on this topic and really look forward to your presentations. I think we have 3 cases and again, a general discussion first of the subject matter. So I'll shut up here, get out of your way, and listen with great interest. Thank you.
Great. Thank you, Jens. Thank you to Seattle Science Foundation for having us again. And yeah, tonight's topic will be sacral fractures. We'll talk for about 20-30 minutes, and then we'll follow up with 3 cases. By way of background, quick overview, we'll discuss the pathophysiology, discussing pelvic stability, fractures, how they come in 2 flavors, low energy and high energy, or secondary to low and high energy, fracture patterns and classification systems, and then others to consider, which the spine surgeons need to know about, which are below prior spinal instrumented fusions that terminate distally in the sacrum, as well as pathologic sacral tumors. And then throughout this, we'll talk about the treatments. 3 cases we presented, one by a close friend and colleague, Dr. Ashraf Al-Naga. He and I actually went to medical school together. He's a spine surgeon and orthopedic trauma surgeon, so dual trained. One of his colleagues, also a close friend, David Gendelberg, who was also dual trained in orthopedic spine surgery as well as orthopedic trauma, presented case. And then one of our fellows, Andrew Swires, will discuss one of Dr. Bervin's patients. So 1,000-foot overview, stability of the pelvis is primarily provided by ligaments between the sacrum and the ilium. And injuries to the posterior ring, anterior ring of the pelvis can result in ligamentous injuries, also osseous injuries, or a combination of the 2. And many times displacement is often due to fractures. The ligaments are quite sturdy. Pathophysiology of sacral fractures, there's those that come in secondary to high energy in patients who are usually young, and we'll have a case presentation of that. You can see here the cancellous structure of a young sacrum, highly dense and quite robust. On the right, you can see a very, very porous sacrum, osteoporotic, and these are the insufficiency fractures, or the fractures that are secondary low energy. The high energy ones are usually associated with some other pelvic ring injury. We won't go into the details of this. That's a whole nother talk. But injuries from the left, lateral compression in the middle, and vertical shear are all that can have a spectrum of injury that can involve the sacrum or the SI joint. The detection of sacral fractures can be quite challenging. Plain radiographs are the standard really for initial evaluation, but as we'll go through in a couple slides here, the identification of them on plain radiographs is extremely challenging, and oftentimes they may be missed. Because of that reason, a CT scan of the area of interest is necessary, and it is the most sensitive. Sometimes it doesn't catch it all. And in those patients, especially those who have a stress fracture, insufficiency fracture, an MRI is what should be obtained. So radiographs, this is a classic image or picture of an inlet radiograph. And you can see here that on an inlet radiograph, this is a patient with a sacral fracture, but personally, I can't tell where it is. And I wouldn't rely on this to make any clinical decision. The one here with the beam aimed from caudal to cranial, about 45 degrees. This gives the view of the sacrum a little bit more en face. And again, radiographs demonstrate a sacral fracture. If you're just looking at the back of the sacrum, it'd be a little bit harder, but some insight about the anterior column. So the pubic ring has a fracture, and this is a vertical shear. But again, radiographs not deal for defining the specificity of the type of fracture pattern. A lateral is necessary, and especially if you're going to do some types of screws that replace, or that we'll talk about here, intraoperatively, just so that people are aware of the nomenclature. The ICD, or the iliac cortical density, is essentially the sacral ala. I can see on the upper right that this is not a good lateral, where the sciatic notches, this small a and small b, are not aligned, as well as the iliac cortical densities, the big A and big B. But on the bottom, you can see here, it's a much better lateral. And a lateral also is lateral sagittal CT scan is first component, which we'll talk about shortly. This is a radiograph of, again, a sacral fracture, and necessary to get a CT. Other things that may give you a little insight into whether a patient may have a sacral fracture are that they may have a L5 transverse process fracture, which is commonly associated with sacral fractures, anterior pelvic ring disruption that you saw in that middle image, and then a paradoxical pelvic inlet view on the supine AP radiograph are all keys that you may have a sacral fracture. We'll dive into some classifications here. Denis classification is one of the most famous ones, broken up to 3 zones. Zone 1, as you see on the image on the right, are those fractures that occur lateral to the sacral foramina. Zone 2 are those that occur transforaminally, and then zone 3 are those that are medial to the foramen, just so that you have the original description, the original reference. Denis zone 1s, in the high energy setting, these are those patients that have a very, very low chance of having a neurologic deficit, less than 5%, although they can have a foot drop depending on, I guess, where the fracture pattern is and the degree of displacement. And commonly it involves the L5 nerve root, because the L5 nerve root transverses over the anterior part of the sacrum. In terms of zone 1 management, I try to distill it into something that's quite appetizing or usable by most spine surgeons. And there's definitely a lot of nuance to this. And so it's not 100% comprehensive, but I think by general rule of thumb, this may suffice. So a lot of the zone 1 injuries can be treated non-operatively. Give them a trial of weight bearing. If they have little pain, they can really ambulate as tolerated and don't have any displacement, then I think non-weight bearing, or excuse me, non-operative treatment is reasonable. The operative ones are those patients who can't mobilize because of a lot of pain, or if they demonstrate displacement of the fracture. The operative treatment for these are quite variable, depends on if it's unilateral or bilateral. If it's unilateral, there's the option of doing an intrapelvic screw called an iliosacral screw. This can be placed at S1. Unilateral also can be considered a triangular osteosynthesis, abbreviated TOS. We'll talk about some variations for how this can be performed. It can be combined with an iliosacral screw, or it can be combined with a transiliac transsacral screw. Bilateral fractures, if you're going to do intrapelvic fixation, a transiliac transsacral screw either through S1 and S2. You can also combine this with the iliosacral screw. So you do an S1 iliosacral screw and S2 transiliac transsacral. Even for a unilateral, there's a lot of different ways you can mix and match these. And then for bilateral fractures, you can consider doing a lumbopelvic. A lot of it depends on what the pathology is, underlying degenerative pathology, say the isthmic spondy at L5S1. But you can consider doing an all intrapelvic lumbopelvic with pedicle screws at S1. And we'll go through some case examples of that shortly. So this is a lady, 60-year-old female, bilateral zone 1 sacral insufficiency fractures, who failed non-operative management. She continued to have sacral pain, couldn't walk very far, a lot of mechanical instability, and you can see here bilateral non-unions. If you look at the lateral, the sagittal CT, there's no kyphosis, there's no translation, so it doesn't look like there's a transverse component. And this was treated with 2 transiliac transsacral screws, one through S1 and one through S2. Didn't have any sacral dysmorphism. On these radiographs, which are about a year post-op, I think you can see some haloing around those screws. And that's one of the challenge with this, is that if they don't heal, then you may be looking at loose instrumentation and then a revision, maybe lumbopelvic, to address any persistent pain from the fractures not healing. I think it's debatable. Some people allow immediate weight bearing on these types of intrapelvic screws. Some people don't. Personally, I think if you're treating a fragility fracture similar to a hip fracture, you should be allowing patients to weight bear and just get up and go. If the fixation is not robust enough, maybe it's not the right surgery. So this is another, 74-year-old male, bilateral sacral fractures, was initially treated non-operatively by one of the trauma folks here, and went home, couldn't ambulate, couldn't walk, 2 weeks, sat in bed, and eventually his family brought him back in. You can see here that they're subtle, but he does have bilateral zone 1 sacral fractures. And then on the upper right, you see the sagittal image with that buckling and demonstrating a transverse component. So this was a patient that we consider doing intrapelvic screws, but in my hands as a spine surgeon, I chose to do an intrapelvic lumbopelvic. So I guess it's not lumbopelvic, but it's S1 screws to iliac screws. And this was all done through a percutaneous approach. He had immediate pain relief and was able to be discharged the next day after surgery. The knee zone 2 fractures, these are a little bit more, a little nastier. They can be associated with, as you saw in those earlier images, with vertical shear. That bottom left image is a pretty gnarly fracture. So neurologic deficit, because it's through the foramen, involves S1 and S2, and based on the original reports, about a 30% neurodeficit rate. When you see a fracture like this, you want to assess, in the bottom left image, say it goes through the foramina, you'd want to assess the CT scan that's in a coronal plane. You want to assess the L5S1 facet. And this is a sign of instability. The reason why the facet's important, because that does help determine some stability relative to the lumbar spine. Isler has a 3-part classification system. Type 1 are zone 2 fractures that are lateral to the L5S1 facet. Those that are type 2, which are through the L5S1 facet joint, and then type 3 on that right pick of the it's medial to the L5S1 facet joint. Interestingly, in this picture, you see the L5 transverse process fracture. They're so commonly associated with sacral fractures that even in diagrams they're included. Type 2 and type 3, there have been some sub-classifications in terms of where it is relative to the facet, displacement, comminution. I think this is a little bit too much detail, but just so you're aware. Zone 2 management, think about it in similar terms as type 1s, but you definitely have to consider the lateral, the facet joint at L5S1, take that into consideration. Non-operative, non-displaced, that are lateral to the facet joint with minimal pain with weight bearing can be considered for non-operative treatment. Operative treatment, those that are displaced, the vertical shears, clearly when the hemipelvis is displaced cranially, I would not advise non-operative management. And then involvement of the facet joint, in my opinion, I would recommend surgery for that. But there are a recent paper looking at the type 2s and where it was relative to the facet, and patients who were treated when the facet was involved non-operatively did relatively well, quote unquote. Again, similar options here in terms of fixation. Iliosacral screws, transiliac transacral screws, it's unilateral. The triangular osteosynthesis was classically described to treat the type 2 fractures, and we'll go into that a little bit more shortly. And those that are bilateral, again, transiliac transacral screws and the lumbopelvic can be considered. So triangular osteosynthesis, this is a really neat, fancy technique, and there's a lot of different ways that it can be constructed. You can do the lumbar fixation up to L5, you can go up to L4, or you can keep it within the sacrum. You can combine it, as you see on the upper left, with an iliosacral screw, or you can combine it with a transiliac screw, transiliac transacral screws, as you see on the upper right. Do the S1 corridor if they don't have any sacral dysmorphism, or through S2. When you're performing it, if you're going to do it, if you're a spine surgeon that doesn't know how to place these, you should call your orthopedic trauma colleague. Thankfully, I have two on the line and many more that are capable of doing this. So it's fun to work with them. When you're doing this, you want to actually put the K-wire across with these screws first, followed by your S1 pedicle screw if you're going to place it. Because if you put your S1 pedicle screw in first, then you try to place these afterwards, your quarter may be gone. One of my old partners, Dr. Murat Pekmezi, did a biomechanical study looking at the stability of placing a contralateral S1 pedicle if the ipsilateral one was compromised and you didn't want to go up into the lumbar spine, and found that this actually was quite stable in terms of axial rotation. So it's another type of intrapelvic, sacral to lumbar to pelvic screw option if you don't want to involve the lumbar spine. This was one of the original biomechanical studies. You can see Dr. Chapman was on that. Nice study from Chip Rout. And this looked at the biomechanical comparison between those patients who had triangular osteosynthesis as well compared to those who had iliosacral screw fixation. And you can see here at the bottom that the triangular osteosynthesis was significantly more biomechanically robust than the iliosacral screws. In the diagram, the box is the the box is the iliosacral screw, and that's it, and the circles are the triangular osteosynthesis. So this is a lady who had a low energy fall, presented a couple days later, inability to walk very much, left-sided sacral pain, buttock pain. And in my opinion, she failed non-operative management. She fell at home, and for 4 days she couldn't walk, and she came to the ED. And you can see here she has a zone 1/2. Kind of depends on what cuts you look at, but it is a zone 2. And interestingly, on the axials, not so much on the coronals, you can see that the L5S1 facet joint is involved. I think there's a lot of different ways this could be managed, and she did have some lower lumbar pathology. And so I chose to do this with an L5S1 ALIF, and then we perked L5 to the pelvis. And again, immediate pain relief, and was able to walk day after surgery and was discharged the next day. This is a little bit different. This is a 19-year-old patient of mine who has a unilateral chondroblastoma. And you can see here it goes through the sacral foramina. She had S1 type pain, but really her issue was mechanical instability. She couldn't stand or sit. And so the plan was to address removal of the chondroblastoma, which, because it was essentially through and through, we decided that she needed fixation. So we ended up doing an L5S1. We did a S1 pedicle screw to a unilateral pelvic bolt. She does have an isthmic spondy at 5'1", but she's very young and she wanted to save her motion. So we decided not to go up into the lumbar spine, but I think eventually it's gonna come. So that takes us to the higher energy ones, the lumbopelvic dissociations. These come also in a lot of flavors. As you see on the bottom left, these are those that have a transverse component. You can have a lambda, you can have a U, you can have a T. There's all different types. I think the most important thing is you need to assess the sagittal CT scans for this. This usually occurs, or this transverse component, through S2, S3, and it is the weakest zone because of that. On the sagittals, you want to see, is there any buckling? And then you also want to see, is there any kyphosis? And there's a subclassification 1, 2, and 3, and then Strang Bolgeson added his compression of the S1 vertebral body. And these are the patients who require lumbopelvic fixation. I think if it's an acute injury with kyphosis as well as displacement, I would advocate for trying to reduce that. So getting a trauma surgeon or someone who's apt at doing that, I think, is necessary. If it's fixed in that position, then you're potentially looking at change in the pelvic incidence. They become a high PI and their sagittal plane is affected. And if down the road that heals, you may be looking at trying to address it with an S1 PSO. But lumbopelvic fixation allows immediate weight bearing, superior to resisting flexion, extension, axial rotation, particularly with sacral comminution, and it can be performed percutaneously, as we've seen. If it needs to be opened, it can be quite invasive. Clearly, you lose some motion in the low lumbar spine, and then depending on how you place the iliac screws, there can be hardware irritation. But if you bury them below the PSIS or you do S2AIs, that's not really an issue. There's a lot of different ways you can do this. And this is a patient who presented 73-year-old female. She fell 4 or 5 days earlier, buttock, sacral pain, and then some vague urinary retention and bowel incontinence. You can see here she has bilateral sacral fractures. And again, in my opinion, she's failed non-operative management. She's failure to thrive at home over the last 4 or 5 days. So she's tried to walk, but she can't. Then you look at the CT scan on the sagittal, she has that buckling and a little bit of kyphosis. I wouldn't say it's a terrible amount. She already is a high pelvic incidence patient, so it may have increased a little bit. But she also has an isthmic spondy at 5.1 with some L5 radiculopathy, as well as a grade 1 4-5 degen spondy. So in my hands, we decided to do an ALIF at 4:1, and then a percutaneous L4 to the pelvis. And again, she got better she got better very quickly thereafter and was discharged not long after that. She had no residual urinary symptoms and bowel symptoms, so I didn't think that the sacral fracture was causing it. And maybe it was just that she was deconditioned and not really mobilizing at home. But anyways, that does bring up the question of, say, it's a higher energy, or if they do have symptoms associated with the sacral fracture, do you need to do a decompression or not? And the data for this, I think, is really mixed in terms of neurologic recovery. Dr. Chapman, it'd be great to get your insight on this during the discussion period. But this is a study that he led 19 patients with Royal Camille type 2 to 4, Denis type 3 sacral fractures with acute cauda equina. All patients were decompressed, fracture was reduced. They underwent lumbopelvic fixation. You can see here the results. 83% of all patients had full or partial bowel and bladder recovery. 47% of patients with complete injury regained full bowel and bladder function. And there was no evidence of loss of reduction or postoperative neurologic worsening. 26% had a wound complication requiring a secondary procedure. Systematic review of 521 patients reported in the literature of neurologic recovery, regardless of the type of management, decompression or not. 62% had neurologic recovery. No difference between operative and non-operative in terms of neurologic recovery. And in the operative group, decompression and fusion was superior to decompression alone. So take those results as you wish, but be nice to talk about what other people's thoughts are shortly. There are some subsets of sacral fractures that I'd like to discuss over the next 5 minutes. Sacral fractures below prior instrumented fusions. These are patients who have L3-1, L2-1, or even higher, especially if they have iatrogenic flat back, have increased cantilever forces in the sacrum. Then it can result in sacral fractures. This is a patient that I took care of. She had an L2 down to the sacrum, instrumented fusion. You can see here that she developed iatrogenic flat back, very severe coronal and sagittal deformity, and a leg length discrepancy from multiple prior revision hip. She's coronally offset by about 8 centimeters and sagittally off by about 10. You can see here that in her sacrum, she also has bilateral fractures in addition to non-union. And a lot of her pain was coming from the sacrum, but also her deformity. So for this, to address both the coronal and sagittal plane, we chose to do an L5 PSO with lumbopelvic fixation, clearly, multiple rods, about 6 rods across the osteotomy site. And then coronally, she improved down to about 3 centimeters, which I think is acceptable. And then sagittally, she did better as well. I think the remaining driver of her coronal plane is her leg length discrepancy. And we gave her a shoe lift, but her sacral pain, that was gone, and she was quite a happy camper. This is another patient, kind of a gift that kept on giving, patient who had a burst fracture at L3. and at an outside hospital. She presented with back pain, and you can see here she has loosening of all of her screws, so she had a non-union. We ended up addressing both her degenerative pathology below as well as the non-union for an L3 to S1 ALIF and then an L2 to the pelvis. All of her pain improved for a year. She fused, everything healed, but she reported persistent iliac screw pain. She was a swimmer. We took out the iliac screws and she had resolution of her back pain for about 6 weeks, but then she developed new posterior left sacral pain with standing. She had no pain with lying down. CT scan didn't show anything. We got an MRI and she has a zone 1 sacral insufficiency fracture in the sacrum. So as you can see there, we tried to treat this non-operatively, 3 months of protective weight bearing, but she continued to have pain and increasing her narcotic usage. So we addressed this with a transiliac transsacral screw at S2 and an iliosacral screw at S1. You can see there's a little dingleberry there because the superior gluteal artery was hit. So these screws, even though they're minimally invasive, they do have risks. There was no subsequent issues with that, but clearly it can happen. So she kind of got better, 50% improvement, but she wasn't content. She continued to have pain with sitting and remain on oxycodone. Got a new CT scan. We thought the fracture looked healed, but we gave her a left SI joint injection and it gave her moderate relief. She was actually quite happy. So we kind of hemmed and hawed and thought about options, thought about taking out the iliosacral screw and then putting in, maybe fusing the SI joint. But because she already had this issue below the sacrum or below the prior instrument of fusion, we decided to revise her down to the pelvis and did a SI joint fusion from within. And she had complete pain relief. She was off narcotics and was quite happy and could fly again on an airplane. Other topic I'd like to talk about is pathologic sacral fractures. Similar treatment algorithm, but for these, I'm a little bit more aggressive in terms of fixation. I wouldn't recommend the iliosacral screw or the transiliac screw for these. This is a young gentleman, metastatic renal cell, presented with left S1 pain only when standing. He had prior radiation to this area, so he had mechanical instability, and I thought that his S1 was because this sacrum was unstable. It does extend bilaterally. You can see on the sagittal, it has a transverse component. And we decided to address this again, L5S1 ALIF and then PERC lumbopelvic. Because of the prior radiation, I wanted to avoid a huge open lumbopelvic incision. This is another gentleman, older, multiple myeloma, back and leg pain that was so severe he couldn't sit up more than 30 degrees. He had no pain when he was lying down. He also has an isthmic spondy at L5S1. And for this patient, we thought about doing radiation first, but because there was instability, we thought that fixation probably was better, followed by radiation. And for him, we did an L4 to S1 ALIF, and then again, L4 to the pelvis, percutaneous fixation. Again, because of the planned radiation, we wanted to minimize the incision size. So in conclusion, the sacrum is the keystone of the posterior pelvis and is a crucial link between the spine and the pelvis. Sacral fractures are associated with fractures of the pelvic ring, vertical instability, lumbopelvic dissociation, long segment posterior instrument effusions with a lower instrument of vertebra S1, tumors. CT scan should be how you make your clinical decision making. And MRI, if the CT looks normal, get an MRI because it's useful for occult fractures. And you need to scrutinize the fracture pattern very closely because these can be challenging to assess or to diagnose. My, cut and dirty algorithm is as follows. First, I assess the axial CT scan, see if there's a fracture. If I see one that's zone 1 or zone 2, I then look at the coronal CT to assess the L5S1 facet. If the L5S1 facet is involved, then I'm very hesitant to offer non-operative management, but I think you can consider it for the right patient. And then there's all the other options, triangular osteosynthesis with iliosacral screw, transiliac transsacral screw, or you can consider bilateral lumbopelvic if they have potentially bilateral sacral fractures. of this type of pattern. If this L5S1 is not involved, non-operative management definitely is at play. And then if you have displacement, can't weight bear, et cetera, again, lumbopelvic fixation of some sort, or the intrapelvic screws can be considered. But again, those other ones may not be the most robust fixation, especially in poor bone quality. After I've looked at the coronal, I then make sure I look at the sagittal, see if there's kyphosis or displacement. These are the patients that, in my mind, should have lumbopelvic fixation. And again, they don't have any kyphosis, whether it's acute or chronic. I think in situ fixation's reasonable. If they have kyphosis, if it's acute, I would reduce it. And then if it's chronic and it's healed, then S1 PSO can be considered if they have sagittal plane imbalance. So thank you very much. We're at kind of the 30-minute mark. So if we want to ask a question now, or if we want to just jump into the cases, I'm happy to do either one.
May I just ask one question? This is Jens Schaub in Seattle. So first of all, beautiful talk, beautiful graphics, nice facts. Back to classifications, is there such a thing as a bilateral zone 1 injury or zone 2 injury? That case that you showed, for me, this is almost impossible, and they usually are a H or a U type fracture, and we just haven't looked close enough for the transverse fracture, so it should be a zone 3. I just don't think there's a mechanical possibility to have bilateral zone 1 injuries. I don't know what you think about that.
Yeah, I think that's a great point. I think with high energy ones, that definitely holds true. I'm not sure about the low energy, just sacral insufficiency fractures. I think it's possible, but when I see bilateral fractures, I do scrutinize a sagittal CT, and I'm very, very hesitant to say that they don't have a transverse component. Ash, David, what do you think?
Yeah,
I
think. Oh, go ahead, David.
Yeah, I think I agree with you. It needs to be scrutinized, but you could also have an APC type 3, kind of an open book pelvis, where if it fractures anteriorly as well, then you could have a situation where you don't necessarily have the transverse component.
Yeah, and I think it's a great question. I think so. The AO Spine recently, or a couple of years back, put together their Sacral classification, where they put together all of the classifications that you mentioned, Alekos, like the Isler, the zones, and there's C-type fractures. One of their subclassifications are these bilateral vertical shears, and those are considered lumbopelvic dissociations because the pelvis is no longer neither hemipelvis is connected to the spine. So I think even if you don't see a transverse, it still sort of behaves the same in terms of the spine is no longer connected to the pelvis, and I would sort of treat them along that pathway.
Absolutely.
All right, great. Well, let's jump into the cases. So the first case will be presented by Ashraf Naga, and Ash, you just let me know when to proceed. I'll run the slides.
Yep. So this is a 42-year-old gentleman who I treated with one of my trauma colleagues Christmas before last, who left from a building 40 feet in height. He came into, and so we can so when he came in, presented to the trauma bay. You could click Alekos there. Yeah. He's hemodynamically unstable. In terms of these patients, they all have their trauma workup, their initial trauma survey. So he was, his airway was intact, breathing was intact, but of course he was known to be hypotensive. The AP pelvis demonstrated a widely displaced pelvic ring injury. And so he was placed into a pelvic binder. Next slide. And in the binder, you can see that closed down his pelvic volume quite a bit. And then from the bay, he went to IR for embolization. The other injuries that he had included the things listed at the bottom. So retroperitoneal hematoma, rib fractures, linear laceration, bilateral open foot fractures, hemothorax, lumbar TP fractures. So we're not going to spend too much time talking about those. So on the first, and then this was the, after he was initially stabilized, this was a CT scan of his pelvis, both the axial, a representative axial CT scan, as well as a 3D reconstruction. I pretty often find the 3D reconstructions to be pretty helpful now that they're pretty easily available and immediately available. So this is in the binder, so that's why his pelvis is closed down. To me, the things that sort of stand out right away are the SI joint being wide on the right side, and then the vertical displacement of the sacral fracture on the left side. So after he was initially stabilized, we could go to the next slide. He went to the OR with one of my ortho trauma colleagues who provisionally put him in a provisional external fixator. And then for his bilateral open foot fractures, he underwent a washout for those open fractures and fixation. And so this is his CT scan in the 3D CT scan, and this is this CT scan sort of in the external fixator. And I think, we can discuss this, towards the end. And the question is then like, all right, well, it's clearly a multiplanar deformity, but how do we sort of simplify this to, individual components that we can address and develop a plan? And so for these pelvic ring injuries, for the young, as Alekos had mentioned, they typically involve both the front and the back. And so it's easiest to start where the reduction is the easiest. And so looking at this pelvis, clearly the front is easier to line up. So the plan is to start with the front, get that reduced. Next, the SI joint, trying to get that compressed on the right side to get that reduced. And then for the left hemipelvis, the things that we want to do is to bring it down and to compress it. And so for any of these vertically oriented sacral fractures, we absolutely, like, one of the goals of surgery or techniques, regardless of whether you have a spine-based instrumentation technique or the iliosacral screws, is we need to generate compression against along those fracture lines. Because if we don't get any compression, then it's a non-union generator. And so that was sort of the order of what we, of how I plan to address this. The question then is whether or not we need to fuse or not. And this goes back to assessing the L5S1 joint, as Alekos highlighted in his talk earlier. We have the Isler classification, which I'm not going to talk about because it was beautifully summed up. And so in this patient, looking at the particular fracture, the SI joint, the L5S1, it's non-displaced. It's hard to tell the integrity of it just based on the 3D CT scan. So we're not going to make a decision at this point. So once we planned and the patient was stable enough to undergo fixation, we start off with the anterior ring, got that lined up, put a pelvic plate. This plate is still flexible enough to allow manipulation in the back. And then the next step was to compress the SI joint. And so this was done with the iliosacral screws, which are really great at generating compression. And so you can see the screw going down here over the next couple clicks, really closing down the SI joint there to get it reduced. And then there was enough space or real estate for a secondary screw into S1 on the right side. And so now the rest of the work needs to be done posteriorly. And for these high energy traumas, the things that we often underestimate is the soft tissue injury. So this was not our approach. This was sort of the underlying fascial disruption. You can see that the iliac crests are sort of marked out there, and you have the hemipelvis on the left side, patient prone proximally. And so when we're doing these approaches, these are not approaches where we're using very little bovie, trying to maintain the remaining vasculature, being cognizant of the fascia and trying to repair any fascial defects that are repairable. So once our clamp is in, the first step was, the way that I tried to bring the hemipelvis down is really get 2 points of fixation. So I put in a standard 4.5 millimeter cannulated trauma screw. This is not a pedicle screw up in the L5 pedicle. And then we put another screw in the ilium. And then we use one of these clamps that we often use on the trauma side. So it's this young Bluth clamp that you see in the bottom left there. This is a clamp that attaches to these screw heads, and you can either bring them together or move them apart. And this is a picture from this patient where the cranial tine is secured to the L5, the screw down the L5 pedicle, and the distal one is going down the end plate. So here, these are the fluoros. This is sort of the outlet views. Have the superior ala on the left side highlighted in white and sort of a dashed line for the S1 end plate. And that's where we started. And then just by distracting the clamp, we can sort of bring that hemipelvis down. It's a pretty powerful technique until we get it symmetric with the other side. So now that we brought the hemipelvis down, we need to figure out how we're going to get it compressed. And if you look at the inlet view, which gives us a view of how of our diastasis, you can see there's a fair amount of diastasis there. We use our provisional clamps just to get it in the same ballpark. So the next fluoro shot, and then from there, we want to generate compression, and we generate compression with a transiliac transsacral screw in the corridor. Yeah, and so the question is, so these iliosacral screws are really great at generating compression, but they're not great at resisting shear. And so we supplemented the fixation on that side with an L5 with sort of unilateral lumbopelvic fixation, exchanged our cannulated screws for the pedicle screws mostly, essentially. You can see the cannulated screw I used in the ilium, the head broke off. It was entirely within bone, so we left that there. Looking at the L5S1 capsule directly, the capsule was intact, so I planned just not to fuse and planned for a hardware removal at 6 to 9 months. And there's our lateral. And so this, you can see the picture of our iliac screw there. And so especially for trauma where there's an overlying soft tissue injury, you really need to get the tulips underneath the PSIS, so underneath the fascia. These patients, it's very common for them to lose 20 or 30 pounds over the next 6 to 9 months. And so screws that may not start prominent may become prominent during the rehab period. And you could also note that these screws, we use typically nothing less than a 100mm screw. This is a 100mm screw, and we have another 20mm left in space, especially in the acute trauma setting. That's our goal. So in terms of our next, so these are the our AP inlet and outlet films that show that the pelvis is symmetric. There's our 3D. And so in terms of follow-up, so at 7 months, I removed his L5 to ilium screws and then some probably 2 months ago. And his main complaints were really his pain secondary to his bilateral midfoot injuries, as well as some residual neuropathic pain from his plexus injury from that vertical shear pattern. And so I think on the next slide, we sort of have a 3D picture of where we started and where we ended. And really, this is in order to sort of have this result, we have a pretty good relationship with our orthopedic traumatologist. But one of the things that we can offer in the spine side is our spine-based, sort of reduction techniques, and then the supplemental fixation that can subsequently allow weight bearing if the patient doesn't have any other lower extremity injuries that preclude weight bearing.
That's beautiful, Ash. Absolutely beautiful. Any questions?
Wow. I mean, yeah, this is fantastic. The key things here are, I think, vascular resuscitation, role of angiography and devascularization of gluteal muscles by the angiography, and concurrent soft tissue trauma like bladder injuries and things like that. This is a life-threatening injury. Obviously, this is beautifully done and shows a lot of subtle and big picture insights both together. So just if you can address angiography, role of angiography and problems of angiography in terms of myonecrosis and management of, let's say, a bladder injury when you have a symphyseal disruption.
Yeah. So those are two very great injuries, questions. So in terms of the, we're always, so we have a pretty good relationship with our interventional radiologist. We typically only reserve interventional radiology if there is an arterial bleed and we coil that. And then as much as we can, we try to avoid the use of non-selective embolization. Which really requires a discussion with the interventional radiologist because it's, depending on the institution, it's really sometimes it's hard to get them not to do something if the patient has already made it to the angio suite. And the incisions that we typically have the greatest problems with after embolization are acetabular incisions. When you knock out the SGA, in terms of pelvic ring injuries, I think it's sort of a matter of religion. So, for me, it just depends on how clean I feel the field is. I may, plate the anterior plate in the setting, but in some patients, instead of doing an anterior plate, I'm using an external fixator. We're actually part of a multi-center retrospective study right now across 10 sites, trying to look at outcomes for this very specific question.
Wonderful. Well, Ash, you saved his life and made the CT scan look beautiful as well. Nice job.
It was a team effort.
So we'll go on to the second case. It's going to be presented by one of our fellows, Andrew Sawiers. He's going to present a case of Dr. Sig Burbans.
Hi, good evening, everyone. Thank you for having me. So we'll get started here. This is a 73-year-old gentleman with a past medical history of prostate cancer, status post brachytherapy back in 2007. And afterwards, he sustained sacral insufficiency fractures that were diagnosed in 2021. He failed non-operative management for these insufficiency fractures, and he had transiliac transsacral screw fixation done a couple years ago, May 2022. And then again, 10 days after this fixation or fracture, he presented to Dr. Burbans' clinic with complaints of right-sided pelvic pain and lower back pain with difficulty walking, requiring the use of a walker. So as we said, his past medical history is prostate cancer that was treated with brachytherapy, degen scoliosis that is well known, hypertension, TIA. In terms of past surgical history, he did have he had bilateral knee replacements in the past, and this fixation of the sacral insufficiency fracture 10 days before we saw him in clinic. And this is motor exam, notably deficits in the tibia and the EHL on the right side, as well as the gastrocnemius. These are the images immediately after his transiliac transsacral fixation surgery, showing that he had 2 screws placed and they're well fixated without loosening or loss of reduction. But here we see, these are the x-rays that were obtained in clinic 10 days later, AP inlet outlet views. And we see, if we look at the left side of the SI joint where the screw threads were passing by, that there was some loosening of the screws and backing out. And again, these are Judet views showing that there's about 1.5 centimeters of loss of reduction of these screws. And this is a CT scan further demonstrating that the screws are backing out. And we see here the sacral insufficiency fractures that have failed to heal at this point. And this is a CT scan, sagittal cuts, showing that this patient also had bilateral L5 pars fractures, consistent with his long-standing degen scoli. And the MRI is showing multi-level degenerative scoliosis. There's a spondia L5-S1 and central stenosis going down from about L3 down to S1. And here on the axial cut of the MRI, we can see there's some highlighted T2 weighted signal showing that these fractures are chronic and they've been failing to heal both on the right side and the left side of his sacrum. So the plan first in place was, is this pain on the right side coming from the loosening of the screws? So we scheduled a follow-up appointment for him with his trauma surgeon to remove the loosened screws, which didn't end up happening. However, he continued to have pain in the lumbopelvic region, most notably with standing. He also had pain radiating to the right foot. And the plan at this point was to address both his bilateral L5 pars fractures, as well as the sacral insufficiency fractures, with circumferential fixation from L4 to S1, utilizing an A-lift through the anterior approach, and backing up the fixation posterolaterally with fusion from L4 to S1 with S2AI screws. So these are the postoperative images showing the hardware is in place and everything went well. And at 2 months follow-up, the symptoms were improved. And we see here that the motor exam is improved post-op from pre-op. However, he was still walking with a Trendelenburg sign with about 4 out of 5 strength in his hip abductors. And at 4 months, this patient continues to do remarkably well. He's no longer using a walker. He's now using just a cane sometimes to ambulate. He sometimes has, this pain has changed from really pelvic pain, intrapelvic pain, to just radiculopathy that is well managed with gabapentin. And there was a CT scan obtained at this time interval, which demonstrated some heterotopic bone ossification on the right side where those screws were backing up. And these have been well managed in most recent follow-ups with CT-guided injections to this heterotopic bone. And these are the CT images here. We see on the right side at the top, there's that heterotopic bone that's bothering him. However, he continues to state that his life is much improved, and really he goes on to say that was a life-saving operation that he had. And that is the conclusion of the case. And I want to thank you guys all for your time, the time that you've given me today.
Thanks, Andrew. Sig, are you on? Maybe not. I think any questions from the audience? Jens or anybody else? Ash, David?
I think it's an interesting case, and I think Sig did the right thing.
Yeah. What do you think the reason for the loosening of the initial transiliac transsacral screw is?
I mean, I think we put these screws in across joints. We believe that those joints have very little motion, but we're not doing a primary fusion, right? And so I think there's going to be a subset and so it depends on what the reason was. So if you put those, I think it's a question that we have yet to answer because, with the placement of iliosacral screws without fusion, there's a small subset of patients who will go on to develop, now you have, you may have persistent pain because it's almost acting like a pseudoarthrosis or, and I think the key sort of moving forward is trying to identify which patients, because it's a small portion of the denominator, is which ones may be sort of amenable to, where who may potentially benefit from an initial fusion or not, So I think that's a question that's where I know there's some, prospective studies being organized now, and I think those will be sort of quite informative. So we'll sort of see where that data shows.
Yeah. Okay. Well, I'm going to give David Gandelberg some time. He and I were, I think, the same fellowship year, and we've been in different paths, but we've ended up in the same place. So, David, it's been fun having you as a colleague, and I look forward to your case.
Yeah. So this is a 54-year-old male who was involved in a motorcycle accident who has this history of L-theta S1 fusion with this axial lift. In addition, he has this left hip dislocation. And if you look at his images, you see diastasis of the left sacrum as well as vertical displacement of the left hemipelvis. Looking at that axial cut, you can see that the axial lift actually precludes the corridor for a transiliac transsacral screw at the S1 level. So if you go to the next slide. So he was hemodynamically unstable, and so one of my colleagues reduced the hip and put him in a pelvic external fixator. And after the volume of the pelvis was controlled, the patient's vitals actually stabilized. And so we watched him in the ICU a few days till he was a bit more stable for definitive fixation. And so as you can kind of see on these images, you have a vertical displacement of the left hemipelvis, you have diastasis of the left sacral fracture. And so it's not quite reduced. And so kind of the plan that we were going at was that this would likely need an open reduction. And so me and one of my trauma colleagues together tackled the pelvic ring. If you could go to the next slide. And so we plated the front initially to kind of get stability of the pelvis. And then we did an open reduction for the sacrum in the back. And so in this case, it's actually quite interesting because the things we need to control are both the vertical or displacement of the pelvis, as well as to control medial lateral widening or rotation around the L5 screw. And so if you could see, I put a cross connector over here to actually prevent medial lateral instability and rotation about the L5 screw. And then you have the L5 to pelvis construct that prevents the vertical displacement. And as we kind of discussed, soft tissue preservation is quite important in these cases. And so I just linked up the cross connector to the contralateral construct. And so patient was in the ICU, developed delirium. And if you could go to the next slide. he decided to get out of bed, and he fell out of bed, and everything fell apart. As you can see on these images over here, he blew out his L5 pedicle, and he fractured his pelvic ring again. And so now we kind of have the question of what to do now. And so if you go to the next slide, we opened him back up, and on the top left image, you could see where we took the Weber clamps and opened and reduced the sacral fracture. And so in this setting, without having the L5 pedicle competent, I then connected the ilium on the left side up to the L3-L4 construct. But instead of kind of relying on the cross connector, I decided that it may be more prudent to put an actual rod to control for medial lateral displacement. And so I then put an additional iliac bolt on the left and one on the right, and then connected a horizontal rod to control for that range of motion. And overall, the patient did quite well with the surgery. And so here you can kind of see the course of event from his injury film in the top left to getting his X fixed and his initial construct at the bottom. And if you go to the next slide, you could kind of see how that fell apart and what we ended up with at the end.
Nice. Any closing thoughts, Ash, or others in the audience?
No, I thought it was a pretty creative way to usually to generate compression. We're using an iliosacral screw, but the axial lift really gets in the way of of that in that last case. So I thought it was a pretty interesting way to approach that question.
Nice. Well, we have 2 minutes left. And I think the cases, as well as the presentation, are a nice example of the heterogeneity of fractures in the sacrum, the high energy, the low energy. You clearly guys take care of the harder stuff. I just put screws in, minimally invasive for old ladies. But yeah, it's a very interesting topic. I think there's a lot of future work that can be done in this. You know, the whole concept of SI joint fusion in combination with the fracture fixation. So I think it'd be nice to all work together, and much more to come.
Absolutely. Thank you very much, Alekos. This has been.
Hey everyone, this is Linda from SSF. There seems to be an issue with the texting in of credits, just FYI. I've tested it a few times. I think the system might be down, but if you email cme@seattlesciencefoundation.org, I can log everybody's credit for you if it doesn't start working, in the next few hours. I've sent a request in as well.
Thanks, Linda.
But I'm going to share the slide anyway, and maybe it will work for others. It seems to be down for me.
So world-class team effort between spine and trauma, and outstanding presentations didactically as well as in case scenarios with many, many subtle and big picture learning points. The main issues really are being aware of sacral fractures and consistently classifying them, and then being aware of the different technologies, both as eye screw fixation as well as lumbo-pelvic. So thank you very much.
Thank you.
Thanks, guys. Have a good night.
Hold tight for the slide. It's 1270 is